The standard recommendation for cancer screening was built on studies that have now been reanalyzed 3 times. Each reanalysis shifted the conclusion, in some cases dramatically. The recommendations in most clinical guidelines today lag the current literature by a decade, and in a handful of specific tests, the gap is even wider than that. I want to be careful with how I phrase this, because I am about to disagree with at least part of what mainstream medicine teaches about cancer detection. Not wholesale, specifically. 5 specific tests, some of them widely recommended, some of them aggressively marketed directly to you, that the accumulated evidence complicates seriously. And 3 tests that the evidence genuinely supports, one of them profoundly, that your physician has almost certainly not offered you and may not have mentioned at all. Before I go any further, one note at the top. What follows is educational information grounded in published research. If you are currently under treatment for cancer or any related condition, this information is meant to inform conversations with your medical team, not to replace them. The actionable version of what I am about to walk through requires a physician who knows your case. That is the context, and it is important that I say it clearly. I do not see patients, I read about cases. The literature is dense enough to keep me busy. Now, that gap between what is marketed as cancer screening and what the data says about cancer screening is what this video is about. I want to start with a term I am going to plant early and come back to: overdiagnosis. We will name it again in a few minutes, and the precise definition matters more than you might expect. The 5 screenings I want to address, in order: annual mammography across all ages, PSA total as a reflexive annual number, full-body MRI marketed directly to consumers, thyroid ultrasound in asymptomatic adults, and coronary calcium score in low-risk asymptomatic people. These are not fringe tests. 3 of them are in national guidelines. 1 of them is recommended by some of the most prominent medical systems in the country. The evidence behind each one is more complicated than the recommendation suggests. And then I am going to spend the second half of this video on 3 tests that the evidence does support. Tests that fill the enormous blank space in what standard screening actually covers. The first is a blood draw that detects 50+ cancer types simultaneously. The second costs $70 and reveals something 80% of standard metabolic panels miss entirely. The third is a panel of biomarkers that most physicians have never ordered together because no one has told them to. Let me begin. Mammography. The story here starts with a paper from 2012 that changed how I read the screening literature. Researchers at Dartmouth, H. Gilbert Welch and Archie Blyer, published a national cohort analysis in the New England Journal of Medicine. 30 years of mammography adoption data, 1976 through 2008. What they found was that the introduction of widespread mammography screening was associated with approximately 1.5 million excess breast cancer diagnoses over those 3 decades. That is not a rounding error or a contested statistical artifact. 1.5 million excess diagnoses relative to what the underlying incidence would have predicted without screening. Here is where the definition of overdiagnosis matters, and I want to linger on this for a moment because it is not intuitive. Overdiagnosis does not mean a false positive, a scan that shows something that is not there. Overdiagnosis means a real tumor, detected by a real scan, treated with real surgery or radiation or chemotherapy, but a tumor that would have grown so slowly or remained so biologically dormant that the person would have died of something completely unrelated without ever knowing the cancer was present. The fire alarm went off. The room was full of steam, not smoke. Both are physically real events. Only one needs the fire department. Welch and Blyer estimated approximately 31% of mammography-detected breast cancers fall into this overdiagnosis category. Other methodologies, using different modeling assumptions, estimate as low as 10% and as high as 54%. I am not going to pretend the exact number is settled. It is not. The honest answer is that the field disagrees. But at every point in that range, 10 to 54%, the implication is the same. A meaningful fraction of women who receive surgery, radiation, years of hormonal therapy, and the profound psychological weight of a cancer diagnosis would have lived their entire natural lifespan without that cancer ever harming them. Actually, let me be fair about the full picture here, because I do not want to oversimplify in the other direction. I am not saying mammography has no value. There are women for whom mammography has, without question, caught a cancer early enough that the intervention saved a life. That is real. What I am saying is that the calculation changes substantially based on age, personal risk factors, and what the individual woman values more: a small reduction in mortality risk versus a higher probability of treatment for a non-lethal tumor. For women under 50, the evidence of net benefit is genuinely thin, which is why the USPSTF spent years going back and forth on the recommended starting age. For women over 75, the competing causes of death, the lead time bias in detection, and the treatment burden make the calculus particularly unfavorable for most. For women with BRCA mutations, dense breast tissue, or meaningful first-degree family history, the picture shifts significantly toward screening. This is a risk-stratified conversation, not a protocol you apply identically to every woman, regardless of biology or life stage. The second test, PSA total as a reflexive annual screening number. There are two large randomized controlled trials on PSA screening, and they disagree with each other. I am going to give you the strongest version of the case against reflexive screening. The dissenting view is worth knowing too. The PLCO trial, the prostate, lung, colorectal, and ovarian cancer screening trial, run by the National Cancer Institute, enrolled 76,693 men between the ages of 55 and 74. 13 years of follow-up. Result: no statistically significant reduction in prostate cancer mortality from routine annual PSA screening. 0. The European ERSPC trial, running concurrently with a different design, found a 21% reduction in prostate cancer mortality in the PSA arm. Two large randomized trials, opposite conclusions. Smart researchers disagree on this. I am picking a side knowing that. And the side I am picking is not never test PSA. It is PSA total alone, as a reflexive annual number without context, has serious limitations that the recommendation has not fully addressed. Here is the core biological problem. Total PSA cannot distinguish between the prostate cancers that kill men and the prostate cancers that would never cause harm in any meaningful time frame. Roughly 40% of screen-detected prostate cancers are Gleason 6. What a growing number of pathologists have proposed should be renamed entirely to remove the word cancer, because these cells do not behave like cancer in any clinically meaningful sense. They do not invade locally. They do not metastasize. The 5 and 10-year survival rates for untreated Gleason 6 disease are essentially identical to population baseline for prostate cancer death. These are not the tumors that kill men. But once a PSA number triggers concern, the standard clinical pathway leads toward biopsy. And prostate biopsy carries documented complication rates. Sepsis requiring hospitalization in approximately 1 to 3% of cases, significant hematuria, urinary retention, and the psychological sequelae of uncertainty while waiting for pathology. And if biopsy confirms cancer, even Gleason 6, many men are treated. The treatment for prostate cancer, radical prostatectomy, radiation, androgen deprivation therapy, carries documented rates of permanent erectile dysfunction, urinary incontinence, and bowel damage that are not small. The USPSTF gave routine PSA screening a D rating in 2012 specifically for this reason. They revised it in 2018 to a C rating for men 55 to 69, meaning discuss before ordering, not order annually by default. That distinction has not fully penetrated clinical practice. Annual PSA as a reflexive order without a structured discussion is still extremely common. The tool that changes this calculation significantly is the 4K score. It measures 4 kallikrein proteins simultaneously and produces a probability score for aggressive prostate cancer specifically, Gleason 7 or higher, not for prostate cancer in general. The discrimination is substantially better than total PSA alone. A man with an elevated total PSA and a 4K score below 5% has a very low probability of harboring aggressive disease and can reasonably avoid biopsy. That information changes the decision tree entirely. The test costs approximately $250. It is available through standard commercial laboratories with a physician's order. I want to be clear about something. If you have a family member, a father, a brother, an uncle, with aggressive prostate cancer history, or if your PSA has been rising consistently over time, the conversation is different. This is not about avoiding all prostate evaluation. It is about having better tools than a single number stripped of context. Third, full-body MRI marketed directly to consumers. You have probably seen the advertisements. Several companies now offer whole-body MRI scanning, some CT-based, some true MRI, for $2,500 to $3,500, marketed as a way to catch anything early. No physician referral required. The marketing language is designed to appeal to exactly the instinct that makes sense. Wouldn't it be good to know if something is growing somewhere in my body before it causes symptoms? The medical system optimizes for managing chronic conditions. Reversing them is a different optimization entirely. Here is what the evidence on incidental findings actually shows. A systematic review published in the BMJ analyzed 43 separate studies and more than 30 years of incidentaloma literature. Incidentaloma being the clinical term for something found in imaging when looking for something else, or when looking for nothing specific at all. Across these studies, approximately 40% of adults who undergo whole-body CT or MRI receive at least one incidental finding that requires follow-up imaging or further evaluation. That is, 4 out of 10 people, not a rare event. Of those who proceed to follow-up, 78% undergo additional diagnostic procedures, more imaging, laboratory work, sometimes biopsy. The true positive rate through those cascades, meaning findings that turn out to represent a genuine, clinically significant, actionable problem, is 1 to 2%. Read that ratio again. 40% get a finding. 78% of those pursue it further. 1 to 2% of the total find something genuinely actionable. The factory manager who lost the schedule. The imaging system has one function: find everything anatomically unusual in the scanned field. So it does. It photographs every small cyst that has been present since your 40s and will outlive you. Every developmental variant. Every tiny hemangioma in the liver that has no clinical significance and never will. Every adrenal nodule and adrenal incidentalomas are found in up to 7% of abdominal MRIs in the general population. Each one requires follow-up, not because it is likely to be dangerous, most are not, but because the radiologist, by professional obligation and medical legal standard, must report it. The ordering physician, with the same medical legal reality, must act on the report. Insurance reimburses procedures, not conversations. That is why you are reading the paper instead of hearing this from your physician. 1 in 500 incidentaloma workup cascades causes a serious adverse event, procedural complication, significant psychological harm, unnecessary hospitalization. 0 randomized controlled trials have demonstrated that direct-to-consumer full-body MRI reduces cancer mortality in healthy asymptomatic adults. Not a small gap in the evidence. A complete absence. The companies offering these tests are selling peace of mind, and the research evidence does not confirm that what they deliver is peace or that it is medically useful. This is entirely different from medically indicated imaging. If your physician orders targeted imaging based on symptoms, an elevated lab value, or a known family syndrome, that is a different clinical question with a different evidence base. I am specifically addressing the advertised consumer product. Fourth, thyroid ultrasound in asymptomatic adults. I went into this expecting one answer. The data delivered a different one. A 2014 paper in the New England Journal of Medicine by An Hyung-sik, Kim Hyun-jin, and H. Gilbert Welch documented what the authors called Korea's thyroid cancer epidemic. In 1993, South Korea launched a national cancer screening program that included thyroid ultrasound as an affordable add-on to the standard health check package that millions of Koreans were already receiving. The ultrasound took a few minutes. It was cheap. It was bundled. Most participants did not think much of it. Here is what happened. Between 1993 and 2011, thyroid cancer diagnoses in South Korea increased 15-fold. Not 15%, 15 times. In 1993, approximately 7,000 Koreans were diagnosed with thyroid cancer. In 2011, 114,000. The largest documented increase in any cancer incidence in any country in recorded history. And during that same period, while 114,000 people were being diagnosed annually, what happened to thyroid cancer mortality in South Korea? It did not change. 1 death per 100,000 per year, before the screening wave. During the peak of the screening wave, after. The death rate remained flat. The conclusion the authors drew, and the conclusion the broader epidemiological literature has validated repeatedly since, is that virtually the entire increase in thyroid cancer incidence represented overdiagnosis. Tumors detected by ultrasound that would have remained clinically silent for the entirety of the patient's natural lifespan. The surgery performed to remove those thyroid glands, total thyroidectomy in most cases, carries documented rates of permanent hypoparathyroidism in 5 to 10% of patients, vocal cord paralysis in 1 to 3%, and requires every patient to take synthetic thyroid hormone for the rest of their lives. These are not trivial complications. They are permanent alterations to the body's physiology resulting from treatment for a condition that was never going to cause harm. The NEJM called it a cautionary tale. I think that framing is accurate and important. If you have palpable thyroid changes, difficulty swallowing, hoarseness that has appeared recently, a family history of medullary thyroid cancer or Menchu syndrome, or a history of radiation exposure to the neck, the clinical indication for evaluation exists. Those are different. What I am describing is the routine asymptomatic thyroid ultrasound offered as part of a general wellness panel without specific clinical indication. The Korean experience is the evidence on what happens when that becomes normalized at scale. Fifth, coronary calcium score in low-risk asymptomatic adults. The CAC score is a legitimate clinical tool. I want to be precise about when the evidence supports it and when it does not, because the distinction matters. For adults in the intermediate cardiovascular risk tier, a 10-year ASCVD risk of 7.5 to 20%, the CAC score provides meaningful additional information that can change management. A man with a 7% 10-year risk and a CAC of 0 may reasonably defer statin therapy. The same man with a CAC of 300 is in a meaningfully different risk category. In this intermediate population, the test adds information that the risk calculator alone does not provide. That use is evidence-supported. The problem is the direct-to-consumer marketing of CAC to low-risk asymptomatic adults. People in their 40s and 50s with no symptoms, no cardiovascular history, and a calculated 10-year ASCVD risk below 7%. In this population, the USPSTF reviewed the available evidence and found it insufficient to recommend for or against CAC screening. Not favorable, insufficient. The test delivers 1 to 3 millisieverts of radiation, roughly equivalent to 50 to 150 standard chest X-rays. And approximately 15 to 20% of patients who receive the test proceed to further cardiac evaluation within 12 months. Additional nuclear stress testing, CT coronary angiography, or in some cases, elective revascularization. In a low-risk asymptomatic individual, the number needed to treat for most downstream procedures to prevent one adverse event is very high. The cascade is not cost-free in radiation, in procedure risk, or in the anxiety generated by a finding that may or may not require action. The system is not structured to say, you are low risk, you do not need this. The structure runs the other direction. The incentive is to scan, to find, to follow up. The mitochondrial reset protocol takes everything I have walked through in this video and 20 others and turns it into a 30-day calendar. The link is in the description below. Now I want to spend the second half of this video on the 3 tests that the evidence actually supports and that most physicians are not routinely ordering. The first is the Gallery Multi-Cancer Early Detection Blood Test. Single blood draw, one tube. The laboratory analyzes circulating cell-free DNA, fragments of genetic material shed continuously by cells throughout the body, including by any tumors that might be growing anywhere in the body. Cancer cells shed DNA with characteristic methylation signatures. Methylation refers to chemical modifications that control which genes are switched on and which are suppressed. Normal cells have characteristic patterns. Cancer cells, across cancer types and across stages, display abnormal patterns that carry information both about the presence of cancer and, with approximately 90% accuracy in validation studies, about the tissue of origin. Think of the cell's methylation pattern as the shipping label on a package. Every cell that sheds DNA into the bloodstream is effectively mailing a package. The label tells the postal system where the package came from, what it contains, whether something went wrong in the fulfillment center. A cancer cell prints an abnormal label. The blood carries packages from every organ system simultaneously. A single blood draw samples the entire courier network at once. The clinical validation study was published in the Annals of Oncology in 2021 by Eric Klein at the Cleveland Clinic and the Grail Research Team. 6,689 participants, 4,077 confirmed cancer cases across 50-plus cancer types, 2,612 non-cancer controls. Specificity, 99.5%. False positive rate, 0.5%. For comparison, mammography false positive rates run 7 to 12% per screening round, meaning that for every 100 women screened with mammography in a given year, 7 to 12 of them will be called back for additional imaging that ultimately reveals no cancer. Now, here is the number that changes the conversation about what cancer screening actually means. There are more than 50 cancer types detectable in a single Gallery blood draw. Before this technology, the standard cancer screening panel available to a healthy American adult, mammogram, colonoscopy, PSA, pap smear, collectively covered 4 cancer types with reasonable evidence. 4. More than 50 exist. Pancreatic cancer kills approximately 45,000 Americans per year. There is no screening tool for it except Gallery and the PDAC-targeted markers still in trial. Ovarian cancer. 21,000 deaths annually, caught late in the majority of cases because there is no standard early detection screen. Biliary tract cancer, hepatocellular carcinoma outside high-risk populations. Brain and spinal cord tumors, esophageal cancer. These collectively account for a substantial proportion of total cancer mortality, and before Gallery, the screening gap for asymptomatic adults was complete. Nothing. Sensitivity for stage 1 and 2 cancers across all screen types is approximately 39%. That sounds modest until you understand what the comparison is. For the cancers that currently have no standard screening, sensitivity at stage 1 and 2 is 39% versus 0. For the subset of cancers without any existing screen that reach stage 3 in the validation cohort, sensitivity was above 75%. I want to be clear about something. Gallery is not yet standard of care. The Pathfinder randomized control trial is ongoing, and mortality data, the highest bar, will take years to generate. The test is not covered by most insurance in 2026 and costs approximately $950 out of pocket, available through LabCorp or Quest with a physician order. And it is not a replacement for standard screening. Colonoscopy at appropriate intervals remains well supported by evidence, as does low-dose CT for current or former heavy smokers, and pap smear where indicated. Gallery fills the blank space that those tests do not reach. If I had a family member over 60 who was not getting this test annually, I would be recommending they bring it up at their next appointment. The second test. A 2-week continuous glucose monitor, worn once or twice per year. The connection between insulin resistance and cancer incidence is one of the most underappreciated associations in the oncology literature. Rudolf Cox at the International Agency for Research on Cancer, alongside independent work from Edward Giovannucci at Harvard, have documented across large prospective meta-analyses, in Giovannucci's case, 97,000 patients pooled, that chronically elevated fasting insulin and circulating IGF-1 are associated with meaningfully increased risk of 13 distinct cancer types: breast, colorectal, pancreatic, endometrial, kidney, esophageal, prostate, liver, and several others. Insulin and IGF-1 are fuel and growth signals. When a cell receives an insulin signal, it activates pathways that promote survival, proliferation, and energy uptake. These pathways are appropriate when the signal is intermittent, as it is in metabolically healthy adults. When the signal runs chronically high, as it does in insulin resistance, the biological environment changes. It is like leaving the grow switch pressed down 24 hours a day. Cancer cells express insulin and IGF-1 receptors in higher density than most normal cells. They are disproportionately responsive to this signaling environment. The chronically elevated metabolic state is, in practical terms, a growth signal being applied continuously to every cell in the body that is listening, including any cells that are on the path to malignancy. The problem with standard metabolic testing is structural. Fasting glucose and HbA1c, the markers routinely ordered, reflect average glycemic state over several months. They miss what happens to blood sugar for 3 to 4 hours after a meal. They miss the postprandial spike. In metabolically impaired adults, that spike can reach 160 to 180 milligrams per deciliter after a standard meal, returning to a normal fasting baseline by morning. The fasting draw looks fine. The insulin resistance has been accumulating for years. A continuous glucose monitor catches this directly. The sensor attaches to the back of the arm. You wear it for 14 days. It logs blood glucose every 15 minutes, including through every meal, for 2 weeks. The data tells you which foods spike your glucose, what your postprandial peak is, how quickly you return to baseline, and whether you have glycemic variability patterns that suggest developing insulin resistance that no fasting test has flagged yet. 37% of adults who have normal fasting glucose levels show clinically significant postprandial spikes on CGM, defined as consistent peaks above 140 milligrams per deciliter. The insulin resistance is already present. The standard panel has not found it yet. The Libre 3, available without prescription at most pharmacies in the US and online, costs approximately $70 to $90 for a 2-week sensor. That is not a misprint. $70 to detect a metabolic pattern that standard lab work at the same appointment will miss. The target, based on available clinical literature, is a postprandial peak below 140 and greater than 90% time in range. If those targets are consistently missed, that is a conversation to have with a physician about insulin resistance management before it becomes a type 2 diabetes diagnosis, or before the metabolic environment has been running hot for another decade. The third test is not a single test. It is a panel of biomarkers that most standard annual blood work leaves off entirely. And the reason it is left off is not that the evidence for it is weak, the evidence is solid, but that the standard panel has not been redesigned to include it. ApoB100 particle count, LDL particle number by nuclear magnetic resonance, high sensitivity C-reactive protein, homocysteine, fasting insulin. Standard lipid panels measure total cholesterol and LDL cholesterol. The problem with LDL cholesterol as the primary atherogenic metric was documented extensively by Alan Snyderman at McGill University in a series of publications culminating in a major analysis in JAMA Internal Medicine in 2019. Snyderman and colleagues compared ApoB, the actual protein carried by atherogenic lipid particles that physically penetrates arterial walls, against LDL cholesterol as predictors of major adverse cardiovascular events in head-to-head comparisons across 9 large studies. ApoB was a superior predictor in 9 out of 9. They are not the same metric. An estimated 40% of cardiovascular events occur in individuals with normal LDL cholesterol but elevated ApoB or elevated LDL particle number. These are people who have been told their cholesterol looks fine. Put another way, A physician who orders LDL cholesterol without ApoB is answering the wrong question. The question is not how much cholesterol is floating in the blood. The question is how many particles capable of arterial penetration are circulating. Those are different numbers. Homocysteine, an amino acid produced in the methionine metabolism pathway. When it accumulates above 10 micromoles per liter by most clinical thresholds, ideally below 7, it is an independent risk factor for endothelial damage, arterial inflammation, venous thromboembolism, and has been associated in observational data with elevated breast and colorectal cancer risk. It is inexpensive to measure. It is reliably modifiable with methylated B vitamins, specifically methylfolate and methyl B12, which push the biochemical pathway toward homocysteine clearance. The conversion efficiency in adults with MTHFR polymorphisms, which are extremely common, requires the methylated form specifically. High-sensitivity CRP. Paul Ridker's Jupiter trial at Harvard, published in the New England Journal of Medicine in 2008, enrolled 17,802 adults with LDL below 130 but hsCRP above 2 mg per liter. This population had low LDL, the metric that would have been reassuring on a standard panel, but elevated systemic inflammation as measured by hsCRP. Statin therapy in this group reduced cardiovascular events substantially. The implication? hsCRP catches a population of metabolically inflamed adults that the standard cholesterol panel completely misses and assigns to low risk. Reduced to one sentence, the standard lipid panel gives you one imperfect proxy for cardiovascular and metabolic risk. The full panel, ApoB, LDL particle, hsCRP, homocysteine, fasting insulin, gives you 5 distinct windows into the same underlying biology, and any one of them can be elevated in an individual who looks fine on the standard draw. The full panel costs approximately $200 to $400 through direct access laboratory services, walk-in lab, Marek Health, LabCorp patient, Ulta lab tests, in most U.S. states without a physician order. With a physician order through insurance, coverage varies by plan and indication. The conversation to have at your next appointment is specific. Can you add ApoB, hsCRP, homocysteine, and fasting insulin to my next metabolic panel? If your physician agrees, those 4 tests alongside a standard lipid panel cost less than a single imaging study and provide more actionable biological information than most full-body consumer scans. Before I walk through the practical summary, I want to be explicit that what follows is research-anchored education. For cancer-related screening decisions specifically, the practical version requires a physician who knows your case, your history, your family background, and your risk profile. The information in this video is meant to change what questions you ask, not to give you a replacement for that conversation. Now, the shape of this video: 5 tests that the evidence complicates. Annual mammography in women under 50 or over 75 without specific elevated risk factors. Risk stratified conversation required, not a blanket yes or no. PSA total alone as a reflexive annual order without 4K score context in cases of elevation. Replace with an informed conversation about whether 4K score is appropriate before biopsy decisions. Direct-to-consumer full-body MRI without clinical indication. The incidentaloma cascade is real. The mortality benefit is not demonstrated. Thyroid ultrasound in asymptomatic adults without palpable changes, symptoms, or family history of hereditary thyroid syndrome. Korea's experience is a natural experiment we should learn from. Coronary calcium score in low-risk asymptomatic adults. Appropriate in the intermediate risk population, not as a DTC wellness product for healthy people. 3 tests that the evidence supports. Gallery liquid biopsy annually after 50. Single blood draw, 50+ cancer types, 0.5% false positive rate, fills the blank space standard screening does not reach. 2-week CGM wear annually, $70 to $90, reveals postprandial dysglycemia in 37% of people with normal fasting glucose, directly measures the metabolic environment that insulin resistance creates. Advanced metabolic and inflammatory panel, ApoB, hsCRP, homocysteine, fasting insulin. 4 additional biomarkers that between them catch what 40% of standard panels miss. This is not a general attack on cancer screening. Colonoscopy at appropriate intervals, well supported. Pap smear, well supported. Low-dose CT for current or former heavy smokers, well supported. Dermatology skin check in high UV exposure history, appropriate. Clinical breast exam, appropriate. Gallery does not replace this. It adds coverage in the massive gap that those tests do not reach. What I have walked through is not comfortable territory. I am not suggesting you distrust your physician. Most physicians who have been ordering these screenings were trained on the guidelines that existed when they trained. Guidelines that were built on the best available evidence at the time and that have not been updated as quickly as the underlying research has moved. The clinical guideline lacks the literature by roughly a decade. That is the structural problem, not a personal failing of any individual physician. If this video earned its time, subscribing is the way to tell YouTube I should make more like it. Where does this leave you? With specific questions to bring to your next appointment. What is my 4K score if my PSA is elevated? What is my ApoB, not just my LDL cholesterol? Has anyone ordered my fasting insulin? Would Gallery be appropriate for someone with my risk profile? What does the evidence say about full-body MRI for a person with my specific history? These are not confrontational questions, they are informed ones. Physicians who are up to date on the evidence will recognize them. Physicians who are not will benefit from the conversation. The cell biology is not personal, it is not marketing. It is what 3 decades of evidence has worked out, and most of it still has not reached the consulting room. Treat the cause. The symptom resolves itself. Read, test, adjust, repeat.